Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Hey, welcome back to the Equine Vet Connect podcast. We're here in the studio. I've got Dr. Caroline Brown with us today.
Hey, y'all.
Got a pretty great topic. This one was sent in, and I think we had a lot of requests for this topic.
Yes.
So we're pretty excited about it. Y'all keep sending in those requests. We'll keep making these videos. Today, the gastric ulcer.
Very hot topic.
This is, yes. Mm-hmm. We're going to probably have multiple episodes on this as we go. It won't be the last time we touch on this because this one's big.
It's very relevant because we see it across all populations of horses, all disciplines of horses, ages, everything. And just kind of doing my research for this, I started just looking up stats of prevalence of it, and they were saying that there's instances of horses that have 100% affected rate of this. They were going through barns of race horses, and 100% of these horses had it. Yeah. And what I thought was interesting too was they looked at wild horses on safaris, I'm assuming zebras, and they had 30% of these things were running around with ulcers. And which is interesting because, as we'll get into it later, I think a lot of the reason that ulcers kind of pop up, people blame it on management. We're no, if there's wild things running around, even if these guys are affected.
And what's interesting, when they did a survey looking at the number, the causes of poor performance, used to it was musculoskeletal or lameness, then it was airway issues. So congratulations, gastric ulcers. You have made it to the number 2 cause of poor performance in sport horses. So you have replaced the airway.
Right.
And I don't think it's that it's a new thing. I think it's just the prevalence of the portable gastroscopy units being able to diagnose this. My wife once said, Dan, that she's talking about lepto in dogs. She's like, lepto sees us way more than we see it. And I think that's been the same thing with gastric ulcers. It looks at us all the time. We forget to look at it.
Exactly. Exactly. And again, we're going to talk about in this episode is that, with more technology, we can actually, sit here and diagnose it. And it's a, pretty easy procedure that we can do. And more vets, including ourselves, we're able to do it on the farm and have an answer same day and a treatment plan if we need it. So
well, let's dive off into this. Let's talk about it. Gastric ulcers. 2 different kinds, right? And really, I'd say 2.5 different kinds.
Interesting. Okay.
All right.
Yeah. All right. Yeah. Where you go? Okay. Let's see what you got.
Let's see where we go with this. So we got squamous ulcers, right?
Yes.
All right.
So then we have to kind of talk about the anatomy of the stomach with it too. So you've got in your stomach, you have 2 layers. So your top layer is going to be called your squamous epithelium, and that's going to be this kind of protective lining of the stomach. There's a lot of muscles up there, and it's kind of where a lot of the digestion starts to happen. It's more like an extension of the esophagus, right? Kind of, yeah.
It doesn't really have that same mucus protection that we get into on the glandular portion. Right.
And the glandular portion's your bottom part of the stomach, and it's what it sounds like. It's all the glands that are secreting your acid and your digestive enzymes and all of that. So when you have ulcers in these different, areas, you're going to get, they're caused by different things, and we therefore have to treat them different too.
And my favorite word in veterinary medicine, I don't know why I like this word, but where the 2 come together, the old margoplicatus. I don't know why I like that word, but
it's a fun one.
I kind of wonder who decided, we're going to call this the margoplicatus. The plicatus I get, it's the junction of 2 tissues. Where'd the margo come from? But, yeah. So then here's where my half comes in, Dr. Brown. Here's my half. So we have an interesting structure in the bottom of the stomach that's part of the glandular mucosa, but it's called the pylorus. That's the outflow of that's where everything flows out of the stomach into the small intestine. And I guess the reason I say a half, yes, it's made of the same tissue as the glandular. It's made of glandular epithelium. That's the surface covering. A lot more muscle behind it. But also, I think those ulcers respond differently than regular glandular ulcers. This is not scientific. This is ulcers according to Dan.
That meant according to Dan.
So we're going to throw that in as the half. That's like 2.5.
I like that. Okay, I agree with that. All right, I
got you. I'm not
gotcha.
going to say it's a third because it's really just a separate site of the glandular mucosa, but it responds differently a lot of times to treatment. So we're going to call it the half.
Okay, I like that. Yeah, it is the half. It is the half, right? So those are our two, kinds of ulcers that we've got.
Just remember, top of the stomach squamous, bottom stuff of the stomach is glandular. Where they come together is the margula plicatus. Where it leaves the stomach, pylorus. So behind the pylorus, we get into the duodenum part of the small intestine.
Yeah, and those are our two kind of, our big categories of them, and we classify them, into like kinds of grades. So for the squamous ulcers, you'll hear us say that they're on a scale of 0 to 5, with 0 being completely clean, 1 being like, some what we call hyperkeratosis, which is like this kind of thickening of it, but not really quite a full open lesion. And then as the lesions get more open, we start to increase them. So if there's just 1 or a few lesions, we'll call it a 2. 3, we're getting a little more spread out. If we get
a little
more depth too. If we get to 5, our stomach is punctured, so we're going to be having a much different conversation there.
We're perf at that point. Luckily, I've only seen one of those my entire career.
You've seen one?
I've seen one perf. Mostly it's in foals. I had one adult horse with it. Long-term use of NSAIDs. We ended up with a perf. So kind of with foals, it's a little more common to see the perforations. But yeah, so, and it's interesting because the grading scale, it kind of varies. Like you're describing the European scale, which is what we use here, but it can vary from practitioner to practitioner.
Right. So, and that is kind of important too when you are, looking at horses. And one thing we will talk about when we get more into the diagnostics is, not just that initial scope, but the follow-up scopes.
Yes.
To watch, how are things healing, how are things changing and responding to our treatment plans and, our management practices as well. But that is something that, it's important to keep that consistent too. And, with the gastroscopes that we do, we can take images of it so we can compare, what this lesion looks like now versus in 30 days versus in 60.
That's incredibly important. So let's talk about predisposing factors. We thought we had a really good handle on this, and I can tell you I feel like I'm constantly looking through what we think is predisposing factors and constantly getting more and more convinced that, yes, there's some things we should do, but as far as prevention, I think it's, predisposing factor. I mean, it can range from everything, right?
Everything, right. And I think something that's important to know, kind of going back to the anatomy of it, is that horses are constantly secreting acid in their stomachs. And that's, I think, one of these big reasons that we've seen that makes horses maybe more predisposed to getting ulcers than other species that we have, because it's the way that their diet is. They're not meant to have, one meal in the morning, one meal at night. They are grazers. They're eating throughout the day. And so when we get into these management practices where we're changing that structure and they're not grazing throughout the day, they're only getting food in their stomach a couple times a day, yet they're sitting here with this really high acid load in their stomach all the time. And we're not giving them the buffer that they need with the food. And so therefore we're kind of predisposing them to it. So that's, one thing that we've really noticed in these horses, and especially these like big populations that we see where we see lots of horses in one area with these, if we start changing our management practice, we can actually, really decrease the incidence of it. And
I think if you were to get into the one thing that predisposes, I think the management practice, that'd be the one I'd probably say I can really say that has an effect.
Consistently across the board.
A lot of people talk about stress. I don't think stress is as big a player in it as we think. But I do think the way we manage these horses, because like us, like everybody's heard their stomach growl. Well, that's a hormonal response where you go to eat and your body says, "Hey, food's coming." we're going to secrete a hormone called gastrin that's going to go down, and we're going to fire up these acid-producing cells. We're going to start releasing these digestive enzymes. A lot of times we don't think about digestive enzymes in the stomach, but there's proteinases, there's the degrade protein, there's amylase that starts to degrade starch. All that starts in the stomach. Well, those things can also degrade tissue in the stomach as well, whereas, we eat a meal, we start making the stuff. Horses, 24/7.
24/7.
Never speeds up, never slows down, which is also why buffers have a very short time span at work. So I would definitely say the one factor I think that we can control that I think does play a more significant role across the board is how we feed.
Right. Yeah.
Constant. We won't feed from constant. We'll get into that when we talk about management. Clinical signs. What do you see out there?
So, like you mentioned earlier, that kind of poor performance is, I'd say, one of the more common things that we're called out for is these horses that are, they're just not performing the way that they're supposed to. They're getting agitated. They just seem to not have as much energy. That's probably our biggest thing we see. We'll hear the word girthy a lot, where you're just grooming in that spot or, kind of feeling around that area and they get really nippy and they'll try to get you at that side. That can be an indication of some pain. I've even seen some horses that just show up for colic signs and we start working them up for a colic and we can't really find a reason, at least in the, the back half of the gastrointestinal tract. And so, we start looking other places, especially these horses that are showing up with like kind of repeat colic signs and they're looking the same. We may say, hey, let's take a step back and let's go, explore the stomach a little bit. And then actually one of the worst ulcers I ever saw was this horse that she had been on NSAIDs for a long time and it was on stall rest. And she just kind of had this like very mild colic episode, couldn't really find anything. We had her for a couple days and finally we convinced the owner, hey, let's scope her. And like the worst ulcers I think I've seen today, and this horse was just chilling. She's just, kind of a little uncomfortable.
And the great thing is, you're going to change that horse's life.
Oh, yeah. Oh, my gosh.
And let's clarify that. Now, we've been using the word NSAID.
Yes.
Let's define that. NSAID is a non-steroidal anti-inflammatory drug. Steroids can also be in this. So drugs you want to think about, butybanamine. I'm going to throw Equiox in because, yes, Equiox is what we call a COX-2 inhibitor. I mean, it has less effect on the stomach and kidneys than butybanamine. But remember, it's less. It's not a 100% only COX-2. It does have some effect on COX-1. These are different pathways that can lead to ulcers. But also remember steroids, dexamethasone, prednisolone, triamcinolone, betamethasone, depomedrol. All those things can have an effect on stomach ulcers. So it's not just butybanamine. So when you hear say NSAIDs, no, we're talking NSAIDs, steroids, and no, we're talking about this big class of drugs, anti-inflammatories is what we're talking about.
Right.
These effects. So.
Right. And that is, that has been shown time and time again that is a predisposing factor to ulcer development, that horses that are going on NSAIDs, and particularly for an extended period of time, that's what we've seen. And so, one of the management practices that, we will get into later is if we have these horses that are going to be on a NSAID for more than just a couple days, for whether it's a colic or, an injury or something, a lot of times we will put them on, kind of a preventative dose for ulcer treatment, just as a precaution. And
the one perf I saw was actually, it was an eye case. It was a really bad ulcer.
Really?
And we were treating it for a long period of time. And we had an ophthalmologist involved. And we were using very low dose of Banamine. I mean, we're talking about a 250-pound dose of Banamine going to a 1,000-pound horse. So all of us thought we were in the clear. And this was years ago before ulcers were really, we knew as much. And we're talking about probably 12 years ago. And this horse was having colic symptoms. And then when we scoped it, we did find a perforated ulcer.
Wow.
And like I said, the horse was seeing an ophthalmologist. The ophthalmologist was setting the pain control regimens. They were going in weekly. We didn't have as much involvement on what we were prescribing. But I think that was That was a fail across the board because we should have been more proactive and been looking at the reports saying, hey, this horse has been on a long-term NSAID, even though it's a low dose. We should have thought about that. And I look back, and that was before we were really focused just as a profession, before we were paying as much attention to it. Now I think it's like, it's the first thing in our mind. Hey, you're going to be on an NSAID more in a few days. You're getting some gas.
We're going to get, yeah, absolutely.
We're on top of this. So Dr. Brown, I think my horse has got ulcers. What's the next step?
So our gold standard for diagnosing this is going to be a gastroscope. And so what that is we fast a horse overnight, ideally at least 12 hours. Usually I'll go up to about 18 if we're going for completeness. And the reason for that is, we want to get all the food out of the stomach so that we can completely see all surface area of the stomach, all the parts. So we'll fast the horse overnight, and then we will give them a little bit of standing sedation and stick a camera up their nose, all the way down their esophagus into their stomach, and we can look around, and we'll see, the different parts of the stomach we talked about, the squamous, the glandular epithelium, the margo plicatus, and the pylorus. Some of these horses, too, will even kind of go into their duodenum, which is the first kind of couple inches of their small intestine, because there are some, ulcers that we can see in there as well, and that can cause some effects. And so it's a very quick procedure. I know here we're usually in and out in about, 30 minutes. And we can even do that on the farm now too. With our technology, we can, plan it out where we can come out to your farm and do that right then and there and have our answer.
I think that's been the biggest game changer. We've got 3 scopes. Forever, we just had one here in the hospital. We had to come in. Now we've got 3 scopes. 2 of them are portable. One stays in the hospital. It is start to finish from time we sedate till we're done. Usually, sometimes we get it done in 10 minutes. But less than 30-minute procedure to get this done. And the great thing about it is you can see it, right? It's not like, I feel like every time I got an ultrasound up there, everybody's like, I have no idea what you're looking at. But that gastroscope, you get to see it.
Yeah.
It's on a camera. It's on a beautiful screen. We're popping those pictures. We got video. We know that's what we're dealing with.
Exactly. And then, we can take pictures of it. And, as we mentioned earlier, the repeat gastroscope, after we've done, 30, 60, however many days of treatment, we can go back in using that, same camera and look at those areas that we saw and say, hey, this one got better, but maybe this one didn't improve, or this one seems to have gotten worse. So what do we need to do in our treatment plan? And, kind of talk about management and all that.
I think the one thing I preach is the most important thing we're going to do, and if y'all have heard this, if you've been listening to the podcast, we're a very diagnostically driven practice. We truly believe getting the answer and knowing exactly what we're treating is what we need to do. It's going to save time, it's going to save money, and the most important thing is better for the horse.
Right.
And so that gastroscope is the most important thing, because we're going to use, depending on what we see, is how long we're going to treat before we do that recheck. It's going to determine what medications we use, because it's not just GastroGuard that's out there. We're going to get into those later on. But it's going to determine which medications we prescribe. And then also, that follow-up scope you're talking about, critical. We don't treat these to completion. We're wasting time, because what I always say is, if you got a grade 3 ulcer in there and 30 days later we're at a grade 1, symptomatically we're better, but we're still sitting with a grade 1. As soon as we stop treatment,
Gonna come back.
We're right back until we get that stomach to completely heal, because you've got a wound in the stomach. That's what I like to think about. You have a wound in the stomach. That wound has to completely heal, or else you're just going backwards.
Right.
So,
and I think one thing to note too, when you're talking about the grading does not correlate to pain. So I've seen horses that are, absolutely hurling themselves on the ground, writhing in pain with, one spot in their stomach. Yep. And then I've seen other horses that, again, their whole lining looks like it's peeling off. It looks like someone took claws to it, and they're just kind of standing there, just a little uncomfortable.
Oftentimes, I feel like the milder ulcers are more painful than, and I don't really have a great reason for that, but you're absolutely right. There's been no correlation between severity of ulcers and clinical disease.
So, any ulcer we see, we're gonna take it seriously. We're going to treat it. It doesn't matter, how painful or not painful they are, how big the lesion is, or how many there are. We're all going to take them seriously.
I'd probably say the number one horses we're scoping, Grumpy Geldings and Moody Mares. This is before your time, Dr. Brown, but I can remember we used to do standing overectomies here at the practice, and I look back and I can't tell you how many people were bringing in this moody mare thinking she needed an overectomy. And we had a gastroscope, and I had been doing a lot of work with gastric ulcers at the time, and I realized chronic pain can cause bad behavior. And so before we would do an overectomy, we'd require a gastroscope and a layman's exam. So horses were sound, okay. We'd do a gastroscope. And if that was clean, then we may look at doing an overectomy. But I can tell you this, once we started doing the gastroscopes, I don't remember the last mare that I overectomized because of behavior. I did. We've done some for granulosa cell tumors, but my moody mare problems went away. And so I used to do some speaking for Mary L., the maker of GastroGuard. And one of the things I used to tell people all the time was, if you're not scoping moody mares and grumpy geldings, you're missing the boat. You're missing the boat.
Absolutely.
And anybody that's ever seen the behavior change in one of these horses when we clear up the gastric ulcers, it's pretty significant. One test I get asked a lot about, fecal occult blood testing. I'm trying to remember which test that is. That's
so it's an at-home test that I see them all over my social media. They are constantly popping up on my ads. So it's an at-home test that you can do on your horse's manure, where it tests for any sort of blood in their intestine, and it's supposed to tell you if your horse has ulcers or not. And in my experience, when I've seen them, I don't think they're reliable. Because again, I think as we mentioned in a couple episodes ago, horses have some 200 something feet of intestine.
105 feet on
105
feet.
A lot of intestine. So
that's after the stomach.
That's after the stomach. And so blood can kind of be coming from a lot of different places, and ulcers absolutely is place, but parasites can also be a problem, and that can go anywhere in the intestine. And so just because you're getting a positive result on this doesn't necessarily mean that it's caused by gastric ulcers. It just shows that, yes, we have blood somewhere in our intestinal tract, and we don't know if that's up at the top or, all the way down near the anus. We really have no idea in this. So yes, it is a good idea, kind of in theory, but just practicality wise, I'm not going to necessarily say, yes, your horse has ulcers just after doing this one test.
I believe in it so much that I've never used it. And one of the things, going back to getting this diagnosis, is the most expensive medication is the one that doesn't work. All right, and I always think about that. And I don't know who said it, but someone once said, medicine is poison, surgery is trauma, alternatives witchcraft, absent a diagnosis. So if your horse doesn't need the medication, it's no longer a medication. It's a poison. And I remember I had a case that the owner was just absolutely against scoping. 3 months of GastroGuard. Finally, and the whole thing was the horse just didn't want to eat. Finally allowed us to scope. We get into the stomach. And normally I'm going to tell you bots don't cause a problem. But when I could not see a piece of normal mucosa in this stomach for the number of bots that were attached to the wall, I'm not lying. Like, there was not a single, there's a picture here on a computer somewhere of that scope. This thing was literally wall-to-wall bots. Normally bots, not an issue. 3 or 4 of them, not going to be an issue. These are fly larvae that attach to the lining of the stomach. You've probably seen little yellow eggs on your horse's legs. They lick those off. They attach to the lining of the stomach wall. They grow and then later pass out through the manure. So after 3 months of GastroGuard, we see bots. We grab a $10 tube of ivermectin. The horse is back eating fine. She's now one of my biggest proponents of scope the horse. I mean, we were $3,000 deep on treatment, and her whole thing was like, I want to save the money on the scope. We way outspent the scope. Needed a $10 tube of ivermectin. And the crazy part is I didn't even see that many eggs on the horse, and I found out that she was been removing them. but this horse was literally lined wall to wall with bots. Only case I've ever seen that on, but again, get the answer. It's a quick, simple procedure. Your horse doesn't even remember it. So, we get into treatment, and again, we've got a diagnosis. We know what type we're treating. We know the grades. Let's talk about what's out there. This is where we're gonna get into some facts. We're gonna into some figures. We're gonna say the things that nobody wants to hear. What works?
So the first drug we're going to talk about is something probably everybody's heard of. It's called omeprazole. So omeprazole is a proton pump inhibitor. So basically this is going to start to suppress acid in the stomach, which is going to help to, get rid of that kind of irritation in there, which is causing all these. And the omeprazole that we are recommending is the product called Gastrigard. Because one thing we do need to know about the way that omeprazole works is when it hits the acid in the stomach, it immediately is going to start degrading. And so a lot of these, already prepared forms of omeprazole that you might see in a drugstore that you could buy for humans, or a lot of compounded products, don't have this protective coating that Gastrigard or UlcerGuard have. And so the second that medication hits the stomach, it gets degraded and none of it is going to work.
I always say it's the candy shell. When you go get an Advil, you've got that candy shell on there. Well, that candy shell is specifically designed so it doesn't break down in the acidic environment. Once it passes into the small intestine, enzymatic degradation removes our candy shell, and we're able to get the drug absorbed. And a lot of people think that the omeprazole it binds to the stomach wall, and that's what shuts it off. But it has to be absorbed in the small intestine. The blood vessels feed it back to the stomach, and that's where we shut off these proton pumps. So if you don't have a candy shell, you're not making it.
Right.
There's other products. What is it, the alprozole, or I call them the Pop Rocks, right?
Yes, the Pop Rocks.
Interesting enough, there was a study done on that, and they never actually got to therapeutic levels in the bloodstream. We never got enough omeprazole. The plasma half-life wasn't high enough to ever control an ulcer. So yes, it has a candy shell, but when you put it to the test, it still doesn't hold up.
Right.
So literally there's one product on the market, and that's Gastrigard. And
we know that it works. We know that it is absorbed. We know how to use it. And that's going to be what we recommend. Now, we have a lot of people that are like, hey, I'm on a budget. I'm going to try one of the other things. And, I'm not going to tell you no, but
and to be the honest guy in the room that's going to tell you what nobody wants to hear. If you're going to use the powdered omeprazoles, I always say sprinkle it on their back, because it does as much good there as it does in the stomach, and it's easier to administer that way. At least your horse doesn't get mad.
Yep.
I'm not a fan of, because like I said, if it didn't have that candy shell, and there's a lot of papers out there. This isn't our opinions. A lot of papers out there looking at plasma half-lives. Does it get to therapeutic levels? There is only one product that gets there.
Right.
Gastrigard, unfortunately, it is expensive. However, the most expensive medication is the one that doesn't work. So I would rather see you spend your money on a medication that does work. Because, these compounded formulations, you're still talking several $100s.
Yes, absolutely.
So you're talking several $100s for a medication that doesn't work. So unfortunately, we're gonna push you. We know it's expensive. There's some great rebates out there. We'll walk you through that. The company, in fact, they tell us the lowest we're allowed to sell it for. That's what we sell it for. We're not getting rich on Gastrigard.
I promise you.
Great rebates on it buying through your vet, and we'll walk you through that process and help you get the best deal we can.
And one thing too, that when we do prescribe Gastrigard, the way that it works is best on an empty stomach.
Yes.
So we always say administer it at least 30 minutes before you feed them in the morning. So, right when you get out into your barn, give them the Gastrigard, wait about 30 minutes, go make your feed, do your chores, and then come back and give them their morning breakfast. Because we have found that the omeprazole is best absorbed when we're on an empty stomach. We don't have anything else in there.
And horses go through a natural fasting period at night. So that's why we really push for that first morning feeding. They go through a natural fasting. I don't know what poor students had to sit there and watch this, but I think we were reading this from 11 p.m. to about 6 or 7 a.m., something in there. So unfortunately, you're going to have to get up early and get this done, which kind of leads us to there is a compounded injectable product on the market. This is you give a dose every 7 days. It's a slow release formulation. It does bypass the oral absorption. It's been a very good product. However, I've had quite a few have some pretty big reactions to it. I don't recommend it that much unless if I'm not making any progress with Gastrogard. I may look at the injectable. We're going to have a long talk about the risk associated with it.
Right. And again, it is a compounded product. I think there is a labeled product maybe in Australia or something. So
they're working on
they're working on it. Yeah.
So it has not come to market yet. Ben Sykes down there has been working on that.
Yeah. But it is something that is available as well that we, if your horse is diagnosed with ulcers, that is something that we can talk about and, ask your vet, go through the hey, what's going to be the best option for me and my horse and our situation.
Correct.
So that's omeprazole. The next drug we're going to talk about is a drug called sucralfate. Sucralfate, all reliable. And so sucralfate, the kind of goal of it is to kind of help coat the lining of the stomach. And it's been shown time and time again that administering sucralfate with omeprazole is going to be superior for treating ulcers than just doing the omeprazole by itself. And this just has to do with, I think it has to do a lot with pain in treating these things. I think it has to do with the absorption of everything and just kind of protecting that lining of the stomach and preventing those ulcers from getting worse as we're treating them.
I think about it like the Band-Aid for the stomach because it won't bind to normal tissue. It only binds to that submucosa or that tunica muscularis layer. That's where it's going to bind. And I always think about it's forming that Band-Aid. It's almost acting as the body's way to protect it.
Yeah.
So forming that Band-Aid, and that's our big thing with sucralfate, putting a Band-Aid on there.
Yeah.
Is it going to cure it? Absolutely not. We've got to increase the pH in the stomach, but it does give us that Band-Aid.
And I've had a lot of horses that I've been kind of in the middle of treating, and for whatever reason we only started with Gastrogard, and the horse is still just uncomfortable. We're not really getting the response that we need. But then starting them on that sucralfate,
yes,
it's you almost see them relax.
Right.
Once that sucralfate kind of kicks in, it's
It's kind of a pain. We're talking 3 times a day.
Yeah.
And one of the things I've joked about, you want I think it's pink in color.
It's either pink or white, but it's mostly pink.
The white doesn't like to dissolve in water. The pink does. Unfortunately, the pink costs more than the white does, but we can actually get the pink to dissolve. So we sell a lot of the pink colored omeprazole or sucralfate, and we use some of the compounded as well. Next medication. This is why I feel like the gastroscope is so important. The 2 medications we just talked about are fantastic for ulcers on squamous mucosa. Your horse has got a pyloric or it's got a glandular. What do we need to grab?
Misoprostol.
Prostaglandin analog.
Yeah, so misoprostol it's going to work a little bit differently than the omeprazole or the sucralfate because the mechanism for healing these ulcers in the glandular is very different than, why the squamous ones formed. Just because of the anatomy of the stomach and where they are and, kind of what's going on. So the misoprostol is going to, essentially try to shut down that over acid production. It's going to try to calm some inflammation down in there. And it's,
the way I like to think about it is if you go back to how butyrbanamine or NSAIDs cause ulcers, you heard us talk about COX-1. COX-1 suppresses the production of prostaglandin. That's how it works as a pain control. So what happens when we shut down cyclooxygenase 2 or COX-2, that controls pain. However, COX-1, the role of it is to increase blood flow to the kidney and to the stomach. the point of that is to stimulate. If we reduce that blood flow, we decrease our mucus coating in the stomach. And so prostaglandins, we're basically replacing that prostaglandin and increasing that mucus coating on the stomach that allows for that stomach to heal. So that the misoprostol it's a great medication. Use it a lot, but like I said, it's got a very specific spot, and if you've got glandulars, that's the only one I know that works.
Right. Like we will, and again, a lot of these horses that we are treating for ulcers without scoping them first, we'll throw the omeprazole and the sucralfate at them for, a couple months, and we're not seeing the changes that we need. We're still having symptoms. So when we finally do go in there and we see, there are no squamous ulcers, it's all glandular, we get them on that misoprostol treatment, and it's like night and day.
It is, and that's why we push so hard for that scope, because we've all been there with those people dragging, not wanting to scope, and they've run the Gastrogard, didn't make progress, and it's like, here's why.
Yeah, because that wasn't our problem.
We need misoprostol, and when you need it, it's fantastic. Like
Right.
pyloric ulcers, pyloric and those glandular ulcers, you got to have that misoprostol. And some horses, unfortunately, you get the trifecta, right?
Yeah, you get all of them. You get all of them. Yes.
And then you get all the meds.
Yes.
You get all the meds.
So, and most of these horses too, when we do diagnose them, depending on the grade of the ulcers, how long it's been going on, that's how long we'll recommend treatment for. So for a lot of these horses, we'll start with 30 days.
30 days.
Of, whatever our treatment protocol is, and then we'll go back in and repeat the scope.
Gotta have that.
The repeat scope is so important.
Yes.
I think that's if we can say anything about what this episode is that scope and rescope.
Scope and rescope.
Scope and rescope.
Because like I said, you're 30 days in, you go from a grade 3 to a grade 1, you stop treatment, now you're starting back at a grade 3. If we were sitting there down to a grade 1, like, hey, we're going to do another 30 days and this is going to be healed, we go back in and look 30 days later, work scope's clean, life's great.
Yeah.
If not, your horse just rebounds back, and I feel like now we've wasted a month of treatment. One of the first things also that we discuss when we do find these ulcers is that's when we start asking the management questions, right? What's your horse's diet? What's some recommendations that you feel are really important?
So going back to what we talked about at the beginning, where horses are, constantly secreting acid all day long, the way that we feed and what we're feeding is going to be the most important. So, opting for trying to do very frequent, small, like forage-based meals throughout the day is going to be kind of our best bet. So, for places that can throw hay all day long, great. For places that may not be accessible or they can't be turned out on, grass pasture all day, hay bags are a really good way to...
The slow feed hay net is a godsend.
Just so that, your horse isn't just sitting there gobbling up all their hay in one go, and now they're going to sit for another 8 hours without anything. Now we've got, at least kind of slow it down a little bit and allow them to kind of slowly graze throughout the day and eat that, and then it's going to cause a bit of a buffer. The type of hay that we're feeding is also going to be important. The one thing that a lot of us recommend is alfalfa. So alfalfa is a legume-based hay. It's different than a lot of our grass hays, like our Timothy or our coastal Bermuda. So those legume hays have kind of two things that make them really ideal for ulcer healing. They have a lot of protein and they have a lot of calcium. And this is going to help kind of buffer that stomach and decrease that acid a little bit, kind of bring that pH back up, and that's going to help with, minimizing all the trauma to the lining of the stomach as we are trying to heal our ulcers.
I like to describe alfalfa hay as like Tums for horses, because
Yeah.
the type of calcium in there is calcium carbonate. You've all had calcium carbonate. That's called a Tums. Tums just takes calcium carbonate and makes it into a delicious fruit-flavored tablet. And so when you use that alfalfa hay, you're giving them like a Tums.
Pretty much,
And we talk about that buffer. Buffer's not really working. Well, this is a place where this can help buffer the stomach. because that hay breaks down, it releases more calcium carbonate, and so it's more of an extended release. You pop that Tums in, and I think the last thing they looked at on like a buffer, it was like less than 15 minutes of buffering capacity. Whereas that alfalfa hay, it's a slow release of that calcium carbonate. So absolutely alfalfa hay all day long.
Love alfalfa. Alfalfa's great. And then the other big thing too that we will talk about is, grain in horses. So the one thing that we see with grain is that it increases our volatile fatty acids. And that is it's got the word acid in it. It's going to increase the acid load in our stomach. So in horses that are on grain, but maybe don't necessarily need grain in their diet, we will recommend, hey, let's take that out, or at least let's try to decrease the amount of grain that they're on.
I think that's the other place alfalfa hay comes in as well, is because we can replace some of that grain with more nutrient dense hay. All right, I'm gonna nerd off in a minute. I promise we'll do a nutrition episode one day, but here's just kind of a quick snippet. What I like to tell people: a horse eats 2.5% of body weight a day. So if you got a 1,000-pound horse, it can eat 25 pounds of total diet in a day. We want no more than 1% of that, 1% of body weight as grain. So a 1,000-pound horse is 10 pounds. One of the most important things you can do is find out what your scoop weighs. I carry a digital kitchen scale because I am that nerd. I got a little digital kitchen scale. I'm out there weighing because people are like, I'm like, how much do they eat? Like, well, 2 scoops. Well, how big is your scoop? Because I've seen scoops and I've seen scoops. So guess what? We're going to go get your scoop. We're going to weigh that scoop. And my rule is I want less than 10 pounds a day as grain, and I want a minimal amount of grain. Like 10 pounds is my upper limit. That's not where I start.
Right.
The lower I can get that, and again, I think that's where alfalfa hay comes in, because I can replace some of that grain with a higher quality hay. And then I'm feeding less of that grain. So we're winning 2 ways there. 2 ways.
Exactly. Exactly.
And then dividing that up, sometimes you don't want to go out and give your horse 10 pounds of grain at the feeding. My rule is I try to stay, my goal if I can is to stay under 3 pounds per feeding. I will stretch it to 4 in some cases, but I would rather have 3 3-pound feedings than 1 9-pound feeding, or even 2 5-pound feedings. If I can do those 3, it's even better.
And again, going back to how horses are naturally supposed to eat. They're not like us, or like, dogs and cats where you just kind of feed them a couple times a day and we're good. They have to be kind of constantly grazing.
Yes.
So that's very, very important.
And then prevention, again, management practices. It's all about management practices. If we can follow the same things that we're talking about from a feeding program, if we can follow those same things, I think we can prevent a lot of them, or at least minimize our risk. There's still going to be times. So a couple quick tips on prevention.
So I think looking at, what are our increased risk factors for it and trying to intervene there. So one of our things is long-term NSAID use. So if you know your horse is going to be on bute or Banamine for more than just a couple of days, giving them some Gastrigard and Sucralfate while they are on that treatment is going to help just try to minimize that risk. It may not fully prevent it, but it's at least going to minimize our risk of developing chronic ulcers. Travel is another one too. Anytime horses are getting out of their normal routine, whether they're going to a show or, they're coming to stay at a hospital for a couple days with us for a procedure. Any horse that we keep here, they all automatically go on Gastrigard, whether they're here for, some lameness stuff or repro or a colic or whatever they are, they're always on Gastrigard when they're here. Just because we know that being out of their normal environment is a risk factor for developing ulcers. So
couldn't agree more. So feeding recommendations, trying to follow what we talked about. If we do have ulcers, we're going to do these feeding practices. I think doing that as well. The preventative dose of Gastrigard. I think those are the big things that we try to do to prevent. Same thing we do if your horse has ulcers, same recommendations. We're going to do that as a prevention. So great topic.
Yeah.
I really enjoyed it. I'm sure there's going to be a lot of comments, a lot of questions. If you do have questions, you are concerned about gastric ulcers, reach out to your vet. They can help you a ton on this. Want to thank everybody for tuning in. Dr. Brown, thanks for being here today.
Yeah, thanks.
Look forward to seeing y'all next time, and y'all have a great week.